I want to turn now, and I was struck by a comment that you made about we see an older patient, and we actually hope now that they may be Philadelphia chromosome or BCR-ABL positive. And that's a real sea change from the way we used to think about these patients. So I want to talk a little bit about that because the tyrosine kinase inhibitors that Bijal mentioned earlier, imatinib, dasatinib, nilotinib, bosutinib, and now ponatinib have really revolutionized the treatment of Philadelphia chromosome-positive ALL and are really turning that from a very poor prognosis subset of ALL into a good prognosis. And I think there's some, I'll say, controversy in our field about can we actually move away from chemotherapy, maybe not completely, but to a much lower level than we had before because we've got such a powerful agent to use in these patients. Bijal, what would you say about that controversy?
I'm not willing to move away from chemo altogether unless I have to. I still try to bring in a little bit of vincristine, perhaps even a little bit of cytarabine or methotrexate for my patients when I can. That said, the TKIs are extraordinarily powerful. And, referencing European data, Sprycel and steroid alone, and it was dasatinib and steroid alone, it was an 8-week course of the dasatinib. It wasn't a planned dasatinib until progression. The median survival on that trial, I recall, was close to 2 years. And so I don't think we know yet whether we can give up the chemo. Personally, I'm a little bit nervous about it because I want to try and maximize what I can get from the TKI. A harder question you didn't ask me is which TKI, and I also can't answer that. I've been sticking with dasatinib mainly because of the blood-brain barrier penetration. I think that the data with ponatinib are very, very provocative, and we'll see how that data evolves over time in frontline ALL. Again, the question being, is it better to do dasatinib than ponatinib? Will you get more mileage, or is it better to start with ponatinib up front and you can anticipate something even better because perhaps you're not selecting for something, you're simply treating the resistance before it emerges or the clones before they emerge with resistance.
Or could you start with ponatinib and then switch so you get away from the long-term use of ponatinib and the risk of vascular toxicity?
That's a great question. Again, I right now, I'm not using ponatinib up front. I still want to see the long-term follow-up data. And then I'll give you a much more educated answer. I think that dasatinib is fairly well tolerated, both on high-dose protocols and low-dose protocols, and that's been our go-to because of the CNS penetration issues. The next question, though, given what Jay, you, and Anjali and the intergroup demonstrated, are we ready for blinatumomab and TKI combinations? And that if you had done that same trial again in the pH positive population, so elderly pH positive.
Yeah, so I do in that patient population, or even in maybe younger patients in the future too. So I think I do agree with Mark about I think we're likely going to get away with less chemotherapy. How less is the question, completely or how little? I think the pH positive ALL is the most changing. I think there's an area that is really it's changing so much, and then there's kind of the lack of a standard, so to speak, and very clear sense of what we will do for pH minus when we get them, or even TAL or frontline regimens when we get pH positive, what induction to use and what consolidation to do, and whether we choose transplant or not. There's whole another questions, but for blinatumomab question, I think there's a role, and I think we're ready. And then for those patients, it's at least during the consolidation regimen, and maybe perhaps in induction too. I think these patients do very well with the TKI, dasatinib plus steroid alone. And the majority may not go into complete molecular remission with this induction approach, and I think that's where the blinatumomab TKI combination kind of comes in useful to get into the MRD negative and to continue the regimen for consolidation. And then there's kind of difficult question what to do after that, transplant, maintenance, which maintenance type of regimen that kind of comes in. But I think having the blinatumomab is kind of quite useful, and that's kind of what I'm using actually blinatumomab in the older pH positive patients as a consolidation with a less intense induction regimen, getting into CR with an MRD positive or negative or close to, and then using blinatumomab as consolidation with a TKI then having that decision of what to do, which I think there's no really good prospective data to guide us
I was
through
going
that.
to say, that sounds very reminiscent of a cooperative group trial.
So,
At least I know.
so there is a cooperative group trial
Yep.
that looked at patients over the age of 65 where they, for pH negative, which you already alluded to, where they got blood followed by pump. And then for the patients who are pH positive, those patients were treated with the dasatinib steroids followed by blinatumomab. And those results are not, I don't think that part of the trials. I know the trial's been completed. It's close to accrual, and I think they're just waiting for further follow-up to hopefully present that data.
Did they continue the TKI during the blinatumomab phase?
Nothing there. You got this. You got the dasatinib plus steroids, and then patients
Yes.
went on to get
TKI, yes,
blinatumomab.
continues.
Yeah.
I think there's another question, how long to continue the TKI, but definitely during the consolidation and during the maintenance too. But once typical quote unquote maintenance of 2 years over, the how long to continue, I think there's a variable practice going beyond 2 years or 5 years, and some of us are a little hesitant to kind of stop it altogether because we're worried about these patients. But then TKI are being continued usually with the consolidation. But another question with these novel therapies is the one, any of the TKI can interfere with the activity of the other. For the blinatumomab, is there a better partner of the TKI? Is dasatinib better than ponatinib or nilotinib, imatinib? So I think there are some questions need to be addressed and answered through this type of clinical trials to see what are the impact of this type of TKI on the T cell activity when you combine at least with the blinatumomab.
In younger patients, we are proposing a trial randomizing patients to hyper-CVAD plus dasatinib or ponatinib. The investigator can choose versus blinatumomab and dasatinib or ponatinib. We'll have to see if that gets approved and moves forward. But
I think there will be a very good study to look at. I mean, there's the real life, the decision. I think that when I see patients after those initial induction, the typical decision is, should I do hyper-CVAD plus TKI consolidation, exactly kind of what you're asking, or the blinatumomab consolidation? So I think it will be kind of good to get a prospective data to address the question.
That'll be a fantastic trial, and fantastic for me because, again, we're now talking about integration of novel agents as frontline therapy for young adults. And I think this is really where I hope, I mean, again, we need trials to prove all of this, but where I hope we ultimately move so we can get away from some of the very intensive therapeutic approaches that we've been giving.